Good afternoon, everyone. Welcome to Medical Grand Rounds. For those of you who are at the Glen, you're welcome to join us in D021312. Otherwise, happy to have you here online with us. Before we start, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please leave your questions till the end. Please enter them in the chat. As well, please answer a brief survey that will be sent to you immediately after the presentation. It will let us know that you were present today. And finally, our speaker today is coming to us courtesy of the Division of Immunology. And I'd like to ask the Chief of the Division, Dr. Chris Tsoukas, to please introduce our speaker. Thank you.
Thank you very much, Nadia. Actually, our division is called Clinical Immunology and Allergy. In the past, we were known as the CIA. And as the CIA, we seem to be under the radar in terms of what we do. We've done some great work in immunology, both cancer immunology and immune deficiency. And today, we're going to hear about something even more exciting. It's my great pleasure to introduce today's speaker, who is Dr. Geneviève Genest. She is well recognized. She's a great colleague. She's an immunologist, an allergist, and a physician scientist based at the Montreal General. In keeping with our traditions, she's the founder of the first and only Reproductive Immunology Clinic in Canada and leads the country's only fellowship program, which is dedicated to the training in this emerging field, an important field. Geneviève wears many hats. She's a clinician, a researcher, a teacher, and most of all, lately, she's been a great mentor. And she excels in all of these positions. She's a recognized authority in her domain. She receives referrals from all over Canada, and is very committed to what she does and to patient care, academic leadership. Our resident physicians not only seek opportunities to work with her in her clinics, but are inspired by her. And so will you. Most recently, she was invited to be a visiting expert at Harvard's Grand Rounds, where she presented her latest work on the immune system's role in recurrent miscarriages. So above all, she's known as a highly enthusiastic and engaging speaker, and I have no doubt that you'll find her presentation both thought-provoking and informative. Jen?
Well, thank you very much, Chris, for the introduction. And thank you also to the Department of Medicine for inviting me to give this talk. I'm not going to be talking about reproductive immunology per se, but I really wanted to talk about a subject that's near and dear to my heart, and that's really fertility planning in the context of a demanding career. So the aim of this presentation is not to discuss what we do in the Reproductive Immunology Clinic, but it's really just to get the conversation going about fertility and family planning in medicine. And I wanted to do so in a non-threatening, neutral, and informative way. And I actually got the idea for this talk during a mandatory online staff training. And maybe some of the staff that are on the Zoom and in person at the Glen might remember this, but we had this staff training about microaggressions, where in one vignette, there was a situation where a female surgical resident felt microaggressed or singled out when one of her staff people asked about her family planning in the context of a surgical subspecialty career. And from her perspective, she was being singled out because this question never would have come up with one of her male counterparts. Now, from my perspective, as a woman myself, this is probably one of the most personally useful, crucial conversations to have in your young professional life. And I felt that having this vignette as an example of a microaggression may dissuade fellow MUHC staff members from initiating the conversation with their trainees or even discussing these matters amongst themselves. And also having such a vignette in a staff training further perpetuates the taboo around fertility, infertility, family planning. So today we're just going to talk about it, and I'll be adding in a few immunologic twists along the way. So in terms of educational objectives, I've kept these pretty loose. So I first wanted to discuss barriers in seeking reproductive counsel for med students, for residents, and sometimes even staff persons. I wanted to understand the factors that are associated with a global rise in infertility, review the pathophysiology of gamete function as parental age increases, and then eventually discuss family planning in the context of a very demanding career. So I'm going to try and squish all of this into a 45-minute period so that we have some time for discussion and so that I can answer questions. And if ever you do have questions that you don't want to ask in front of everybody, my email is on the first slide. So I answer to genevieve.genest@mcgill.ca, and I have an open door policy if ever you wanted to discuss these matters. So in terms of disclosures, I do identify as a reproductive immunologist, and I am married to a fellow physician. So my husband is Dr. Mark Beltempo. He's a neonatologist at the Children's, and together we've had 5 pregnancies. So the first 3 were early miscarriages when I was 27 to 28, obviously not planned. And our 4th pregnancy is our firstborn. This is Emma right here. She's 10 years old. I had her when I was 30, when I was an R5 in allergy immunology, and I took a 6-month mat leave. About 4 years later, and this was a very planned delay, about 4 years later, I got pregnant again, and this is our 5th pregnancy and 2nd live birth. This is Lori. She's 6 years old. I had her when I was a staff when I was 35 years old, and already at that time, I was considered a geriatric pregnancy. Did not feel geriatric at the time. I still do not feel geriatric to this day, but I was still deemed a geriatric pregnancy at 35. I took a 3 months off of mat leave from clinical duties with her and 1 year off research duties. So with pregnancies, maternity leaves, childcare, I'm probably 5 to 7 years behind my husband in terms of career advancement, a choice that I've definitely struggled with, but one that I do not regret to this day. Now, in terms of conflicts of interest, I do receive honoraria from various pharmaceutical companies, but none of those have any impact on what we're discussing today. So this brings us to our first educational objective, which is discussing barriers in seeking reproductive counsel in medicine. So why are we talking about this? Unfortunately, family planning, especially motherhood, is still viewed as an inconvenience or a burden, despite physicians having just as much of a desire for parenthood than any other professional group. And despite accommodation for pregnant trainees, such as parental leave, sometimes even having childcare within the hospital, night call accommodation for pregnant residents and med students, medical training remains a significant barrier for parenthood, especially for motherhood. Now, a recent JAMA survey found that 75% of young physicians will delay childbearing. And when those that delay childbearing are then interested in having a family of their own, a third, so 33%, will experience infertility. And then in young physicians that have not delayed childbearing, more than 50% of them will pass up opportunities for career advancement to accommodate parenthood. Now, a recent literature review, which was published in 2024, also shows a similar prevalence of infertility amongst physicians, with physicians having a 25 to 33% prevalence of infertility, which is roughly twice that of the general population. And unfortunately, there's still a significant gap in knowledge about infertility, fertility preservation options, assisted reproductive technology amongst medical students in both the US and Canada, as well as residents in all subspecialties. So to address this, multiple medical societies have been enunciating these call to actions to address physician fertility planning. And the proposed strategies include education, what we're doing today, but also providing insurance coverage for fertility preservation, which we're going to be discussing at the end of the presentation, and offering support for those undergoing fertility treatment. Now, those last two were still light years away in Quebec and in Canada. So now this brings us back. Oops, sorry, something's popping up. Now, I'm going to talk about our second educational objective, which is understanding the factors associated with a global rise in infertility. So we'll understand together some of the factors that make us more infertile. So some definitions before moving forward, we're talking about fertility, not fecundity. Both of them are not the same. So fertility is the actual number of offspring that are produced by an individual or a population. And fecundity is the possible number of offspring that can be produced over a lifetime. So for example, if I had started my reproductive career at 15 years old and I had finished it at 44, which is the usual reproductive lifespan of a woman, I probably could have sired about 15 children. However, I chose to bring 2 children into this world. So my fecundity is 15, but my total fertility is 2. Now, the total fertility rate of a population is the average number of children that are born to a woman over her lifetime. And infertility is defined by the WHO, so the World Health Organization, as failure to achieve pregnancy after 12 months or more of regular unprotected sex. Now, I first wanted to describe what's happening worldwide. So over the last 70 years, we've seen a global decrease in fertility rates. And as we're going to see in the next few slides, that is not all bad. So basically, this is a picture of the world in 1950, and each country is painted in a different color that represents the average number of children that a woman was having in her lifetime. So if we look at North America, most people in 1950s were having between 3 and 4 children. So the average number of children per woman was around 3.7. Now, fast forward to 2023, and we're seeing a global decline in fertility rates, such that in North America in 2023, you can expect the average woman to have 1.5 children. Now, again, this decline in fertility is not all bad. So basically, this graph is telling us what's been happening over the last 100 years in Canada. So we're bringing this back locally. And basically on the x-axis, for those of you who are in person, on the x-axis, these are years. So we're going from 1921 all the way to 2021 in increments of 5 years as we move to the right in the x-axis. And on the y-axis, we have the average number of children that are born to a woman. And this blue curve is representing the total fertility rates for that given time. So as we can see in the 1930s, an average woman was having probably around 3 to 3.5 children. We see that the fertility rates decreased during the Great Depression and the Second World War, which is to be expected, and then picks up around 1946 during a period of economic prosperity and world peace. And around, the 1960s, women were having more children, so around 4 children per woman. Now, an interesting thing happens between 1960 and 1970. So in 1960, we have the authorization to sell the oral contraceptive pill. And in 1969, we have the decriminalization of the abortion pill and the legalization of abortion. And this really does drop the total fertility rates because now women actually have the choice to decide what their family size is going to be. Now, after the 1970s, we have a further decline in the total fertility rates, and this coincides with women being able to access higher education, urbanization, and more females in the workplace. So again, females are planning their families, such that in 2021, which is pretty much what's happening in 2024, 2025, we're at around 1.5 births per woman, which is below the cohort replacement level, which is 2.1 children per woman. So if we continue worldwide in this same vein, we're going to actually see a population decrease within the next 50 to 100 years, which again is not necessarily a bad thing for our planet. Now, with all of this, with women being able to access higher education and with more females in the workplace, what we've seen over the last 50 years is an increase in the average maternal age at first conception. So if we look at the 1960s, the age groups that were having the most children were our 20 to 24-year-olds and our 25 to 29-year-olds. Now, again, fast forward about 70 years later, and right now in 2021 to 2025, the age groups that are having the most children are the 30 to 34-year-olds and the 35 to 39-year-olds, with a rapid decline in fertility rates in the 25 to 29 years old. So in the last 70 years, the average maternal age at first conception has increased by 5 to 7 years. And we're not just seeing this in women, we're also seeing this in men. So this is not worldwide data. This is not Canadian data. This is US data, but that's the best I could do with my literature review. And basically overall, from 1972 all the way to 2015, the average age at first conception for fathers went from 27 to 31. So we're increasing in paternal age by about 4 to 5 years at first conception. Now, with this global decrease in fertility rates, there is also a global increase in fertility rates, and that's what we're going to explore today. So what we can see over the last 30 years, so we're going from 1990 all the way up to 2017, we're actually seeing an age standardized prevalence of infertility that's increasing annually in women by 0.37%. And that increase has been pretty stable over the last 30 years. And we're seeing pretty much the same thing in males as well, where the age standardized prevalence of infertility is increasing annually by about 0.29%. Doesn't seem like much, but if you add that over the next 100 years, we're going to be in a bit of a pickle. Now, how does that translate into numbers? So in numbers that you can, retain, about 1 in 6 couples will suffer from infertility, and about 10% of women of reproductive age in Canada will need to resort to assisted reproductive technology, which is ART. And interestingly enough, the lifetime infertility prevalence currently is similar in high-income countries as it is in lower and middle-income countries. The only difference in high-income countries is that we actually have access to reproductive care. So we're talking about a lifetime prevalence of infertility of almost 20% in high-income countries. And then you also have to tag on the fact that infertility rates are probably 1.5 to 2-fold higher in physician couples. Now, why is that? So say, for example, you do receive a diagnosis of infertility and you have to consult in a fertility clinic. The usual workup that they're going to do is to exclude an endocrine problem, which usually explains about 20% of cases of infertility. They'll rule out a tubal disorder, which is present in around 15 to 20% of cases of infertility. They're going to rule out ovulatory dysfunction, again, explaining around 25% of cases of infertility. Same thing for the uterine factor. So adenomyosis, fibromas, a Müllerian abnormality will explain or will be co-present in around 10 to 15% of patients with infertility. And then the male factor will usually explain about 30 to 40% of cases of infertility. And more, we're also looking for endometriosis, which is present in 25 to 40% of women with infertility, but we're not entirely sure what the contribution of endometriosis is to infertility. But it's being more and more recognized as a contributor to infertility. So if you go to a fertility clinic and they do all of this workup, 85% of the time they will find a medical explanation for the infertility. 15% of the time, they will not find any explanation to the infertility, and that's the proportion of cases that are increasing over the last several years. So unexplained infertility is accounting for more and more cases of infertility. Now, the two other cases or causes of infertility that have been rising over time are elevated parental age and obesity. So we're going to be talking about those two in the next few slides because, again, that's going to be very important in family planning for our intents and purposes. So first off, parental age, which then brings us back to our educational objective number 3. I'm going to review with you together the physiology of gamete function as parental age increases. So why does parental age affect fertility outcomes? So first I wanted to talk about oocyte physiology, and then we're going to go into the testis. So first, in women, in humans, the ovarian follicles are established during fetal development, such that a female fetus at 20 weeks of gestation will have about 7 million primordial follicles. And these primordial follicles will decline rapidly after birth, such that when that person hits menarche or puberty, she's only going to have around 300 to 500,000 primordial follicles left. And then each menstrual cycle, there's going to be a cohort of oocytes or follicles that's recruited. 1 or 2 oocytes will be ovulated, and the rest of the follicles from that cohort will become atretic, such that every menstrual cycle, the oocyte population declines. So the peak reproductive age is probably between 18 and 31. And unfortunately, after 37 years old, fertility does decline. And this is because as we exhaust our egg reserve or our oocyte reserve, the remaining eggs are of lesser quality. The other thing that happens with increasing maternal age is that there's an inverse correlation between maternal age and the ability to produce genetically normal embryos. So if you're a patient that's undergoing an IVF procedure and you're less than 35 years old, you have an 85 or 60 to 80% chance of making genetically normal embryos. However, after 38 years old, that ability declines quite rapidly, such that if you're doing an IVF cycle and you're 42 years old, your chances of obtaining a genetically normal embryo is probably less than 20%. So why is this? So we're going to be reviewing a little bit of oocyte biology together. Now, oocytes in the ovary are arrested at prophase 1 of meiosis 1. So when that oocyte is selected to be ovulate, it will resume meiosis 1. So at this point, the oocyte is diploid. So it has to enter the first meiotic division and get rid of some excess genetic material, which is extruded with the first polar body. So the mature oocyte, which is haploid, now has one set of chromosomes, but those chromosomes are duplicated. So the remaining homologous chromosomes have to align on the second metaphase spindle of meiosis 2, and then the oocyte arrests at metaphase 2 of meiosis 2. And this mature oocyte is ready to be fertilized. So when the oocyte gets fertilized, the oocyte quickly completes meiosis 2, again extruding that excess genetic material in the second polar body formation. So following the completion of meiosis 2, the diploid zygote, which is the fertilized egg, will now enter the first meiotic division of the embryo, which I have not shown. So notice that it's the oocyte that's directing the process of genetic information allocation. And unfortunately, as oocytes age, the process of spindle formation and chromosome segregation at every single stage, so meiosis 1, meiosis 2, and the first mitotic division becomes less effective, such that we have a higher rate of embryo aneuploidy as maternal age increases. Now, that's not the only thing that occurs physiologically with increasing maternal age, and this is where the immunologic spin is going to come in. Now, unfortunately, aging is associated with a progressive and sustained pro-inflammatory stress, and this is referred to as inflammaging. So this is probably something that you've heard in cardiology and neurology and rheumatology. As we age, we do become more inflammatory. So there's an upregulation of pro-inflammatory cytokines in the ovary. And basically, this will attract leukocytes to the ovary. Now, unfortunately, leukocytes in an inflammatory environment will become alternatively activated, which then further contributes to the inflammation in the organ, either by producing more pro-inflammatory mediators or by attracting lymphocytes to the ovary. Now, this inflammatory environment is also accompanied by tissue repair responses that become maladaptive, in addition to a decreased collagenase activity as we age. So we become more fibrotic with less ability to undo that fibrosis. And this causes collagen accumulation and fibrosis of the ovarian tissue, which then further exacerbates the pro-inflammatory response. And also, interestingly enough, with age, there's an accumulation of senescent cells. So these are cells that occur normally in the ovary, but are usually removed by phagocytes, which are these cells in red. So the normal function of these phagocytes in the ovary is removing cells that should not be there. And when those cells get recruited into an inflammatory environment, they are going to stop performing their homeostatic function. So basically, this leads to an accumulation of these senescent cells, which are resistant to apoptosis and can further entertain that inflammatory environment. Now, anytime you have an inflammatory environment, you are going to have enhanced oxidative stress and mitochondrial dysfunction. And unfortunately, again, as we age, we lose that ability to undo the oxidative stress. So we have certain mechanisms that will lessen the oxidative stress that become deficient as we age. And basically, this can lead to enhanced oocyte DNA damage and mitochondrial dysfunction. So the net result of all of this is a decrease in oocyte number, quality, and function, in addition to an age-related decline in quality. Now, aging also affects the uterus by a similar process. So we know that there's an age-related decline in endometrial stem cells, and these stem cells are very important for endometrial function. They help the endometrium regenerate at every menstrual cycle and self-repair. So if you have less endometrial stem cells, you have less ability to have a receptive endometrium. Endometrial stromal cells, which is basically the cell type that will accommodate the embryo implanting, these cells also will not become or will not be as effective as they are in a younger endometria, and they become less functional as we age. And basically, this leads to decreased endometrial receptivity, decreased remodeling, and will impair placenta formation, because these are basically the stem cells or the cells that are required for a nascent placenta. And that probably explains why women that have a higher maternal age are also at higher risk of obstetrical complications such as preeclampsia, low birth weight, and preterm labor. Now, the myometrium, which is the muscular part of the uterus, also becomes defective with age. And this can also lead to birth-related complications as mom ages. So higher C-section rates, more uterine atony post-birth, and higher risk of postpartum hemorrhage. Now, there are also local immune alterations as we age. So there's immune alterations in both the adaptive and the innate immune compartment with age, and this can actually translate into altered maternal tolerance to the embryo or the fetus. And then finally, the aged endometrium will display different epigenetic profiles than younger endometria, and this could actually affect endometrial receptivity and initial placental formation, and this is currently being explored. And these epigenetic changes can also be altered by lifestyle choices such as smoking, plastic exposure, and obesity. Now, aging doesn't just affect females, it will also affect males. Basically, what we can see as males age is decreased sperm quality. So we have a decrease in the volume of sperm, a decreased sperm count, decreased sperm motility, decreased sperm morphology, so abnormal forms of the sperm, decreased acrosome reaction, which is basically how the sperm gets inside the egg. As the sperm ages, it is less able to fertilize the egg, decreased fertilization capacity, and loss of genetic integrity in the sperm head. And basically, this will lead to adverse reproductive outcomes, specifically infertility, decreased pregnancy rates in assisted reproductive technology cycles, more pregnancy losses, more preterm birth, more stillbirths, lower gestational weight babies. And basically, the aging sperm will age in a similar way that eggs age as well. So we can see that there's a direct correlation between paternal age and decreased sperm parameters, and this is as young as 30. So again, in paternal ages that are higher than the norm, after 30, we can see abnormal sperm parameters, loss of DNA integrity in the sperm head, decreased telomere length, abnormal chromosome structure, so we can start seeing the appearance of translocations. We also do see more sperm diploidy, which can lead to embryo triploidy, so increase the chances of miscarriages. We can see de novo mutations, and we can also have epigenetic contributors to embryo quality that are not the same in aged sperm. So again, it's just important to factor in maternal and paternal age when trying to plan fertility. The other thing that I wanted to just note is that obesity is also associated with adverse pregnancy outcomes and adverse fertility outcomes. So why does parental obesity affect fertility outcomes? We're going to talk about that in a few slides, but what I wanted to share with you first is this publication that was published in The Lancet in 2024. And basically what they did is that they looked at the proportion of the population that was underweight or obese between 1990 and 2022. And basically what they did is they represented underweight as these blue columns and overweight as these pink columns. And they basically looked at each country and regrouped each country by geographic location. So basically what we can see in 1990 versus 2022 is that we have this explosion in female obesity rates over the last 30 years. And this is pretty much everywhere around the globe. And we're seeing a similar picture in males, not as bad as females, but over the last 30 years, obesity has increased in prevalence in just about every population around the globe. Now, in terms of just giving you a few statistics to show you how important weight is for fertility purposes, there is a linear decline in spontaneous pregnancies with body mass indexes over 29 kilograms per meter squared. So we're talking about a 4% decline in spontaneous pregnancies per increment of 2 kilograms per meter squared. So if you have a, 35-year-old who has a BMI of 45, she's not going to get pregnant as easily as someone who's 25 of BMI, for example. There's an inverse relationship between fertility and obesity. So the infertility odds ratio is 3.26 for patients with a body mass index over 30. You have a lower chance of pregnancy and live birth rates in women living with obesity undergoing IVF procedures. And you have an age-adjusted miscarriage risk over 30% for patients with a body mass index of 30 kilograms per meter squared compared to patients with a normal BMI. So that translates into, for example, you have a 30-year-old whose baseline chance of miscarriage is around 10 to 15%. If she has a BMI of 40, she might actually have a 50 to 60% chance of miscarrying her next pregnancy. So that is quite significant. Now, why does obesity affect fertility, and why does obesity affect reproductive outcomes? So as you probably know, obesity is a chronic, low-grade inflammatory condition, which leads to an excessive production of reactive oxygen species, chronic inflammasome activation, and a chronic production of pro-inflammatory cytokines, as well as the saturation of antioxidant mechanisms. Obesity is also associated with peripheral and central anovulation, deficient deficient oocyte quality, and also lesser quality embryos with a higher rate of embryo aneuploidy. And also, obesity will affect how the endometrium is receptive to the embryo implanting. So basically what we think is that obesity in and itself accelerates this process of inflammaging, such as if you have an elevated parental age at first conception and you are also living with obesity, your chances of conception are much lower than the general population. So a few things to think about as we move into our fourth educational objective, which is discussing fertility and family planning in the context of a demanding career. Now, a lot of residents will rotate through my clinic, a lot of residents and a lot of med students. And one of the questions that I often get is, well, what can I do to preserve my fertility? And the answer is, first off, make sure that you're living a healthy, balanced lifestyle. So there's little that we can do as physicians to control the amount of sleep we get and the amount of stress that we're under, but there are other things that we can control, such as what we eat and how we move. So basically what I tell people is to really just find a sustainable, enjoyable, chronic movement pattern. So an activity that gets you moving every day that you derive pleasure from, that can also help you manage stress in your daily life. And then, it's always difficult to be able to get appropriate nutrition when you're very busy. But I find that if we're able to limit processed foods and to eat as much things that we prepare at home with ingredients that you can actually pronounce, that is one step forward in living a balanced and healthy lifestyle. And then for the rest, making sure you hydrate, making sure that you go to your regular checkups, and making sure that you keep up with your dental hygiene is a plus as well. Now, what happens if say, for example, you do want to delay your fertility. So, you're 30 years old, you're either in residency training, or you're a med student, or you're an early staff member that's really just looking to delay the process of conception because you have other things to do before. Well, there's something called elective egg freezing. So this is the ability to go through an IVF cycle and to freeze eggs at a lower age that you can eventually then utilize at a higher age when you are ready to try to conceive. Now, unfortunately, in Quebec, there is no program to fund elective egg freezing. This is all paid out of pocket. So I'm taking pricing from the OVO Fertility Clinic just because they have really nice graphs on their website. But this is pretty comparable pricing to all of the other fertility clinics in and around Quebec. So it's basically going to cost you about $250 to see a fertility doctor to inquire about elective freezing. And this is a fee that is going to be reimbursed if ever you do decide to freeze your eggs. So the cost of actually going through an IVF cycle to freeze your eggs is around $7,000, and that includes reviewing the medication, getting teaching, ultrasound monitoring, all the lab work you need to do, as well as the egg collection and the egg freezing, and it includes also 1 year of storage. Now, if you decide to do 2 or 3 IVF cycles or more, you actually get $1,000 off your next IVF cycle. And we're going to get to how many IVF cycles you need to do to guarantee a live birth. And then after your year of storage is up, so there's 1 year of storage that is included in the initial egg freezing cycle. 5 years of additional storage is going to cost you about $2,000, and 10 years of storage is going to be about $4,000. So how many eggs do I need to freeze to guarantee a live birth? Well, that depends on maternal age. So again, on this graph, basically you have the number of mature eggs that you need. And on the y-axis, you have the probability of live birth. So if you're less than 35 years old, you're here on the gray curve, you probably need to freeze between 10 and 20 eggs to guarantee a 90% chance of having at least one live birth. However, as you age, your probability of having high quality oocytes declines with time. So say, for example, you're a 39-year-old and you're deciding to freeze your eggs for the first time. How many should you freeze to guarantee the same amount of live birth? Well, now you're on this green-blue curve right here. So to have a 90% chance of live birth, you probably have to freeze between 50 and 70 eggs. How many IVF cycles does that represent? Now, the number of eggs that you're going to get per IVF cycle also depend on maternal age. So again, if you're less than 35, you're probably going to get between 10 and 20 eggs per IVF cycle. And usually one IVF cycle should be enough to guarantee you enough eggs for that 90% chance of having one live birth. However, if you're 38, 39, 40, your average number of eggs that you're going to get at each retrieval is going to be between 5 and 12. So you'd probably need about 3 or 4 IVF cycles to get enough eggs to guarantee an 80% chance of one live birth. So that, in terms of cost, would probably represent around $40,000. If you're 40 or over 40, it's not recommended that you bank eggs. You probably have to go through 5, 6, 7 egg retrieval cycles to be able to guarantee, 50 to 70% chance of live birth. And usually most fertility clinics will say, well, why don't you just resort to egg donation? And obviously everything is dependent on the individual, depends on what your egg reserve is, but more often than not, fertility clinics will not recommend that you electively egg freeze if you're past 40 years old. So a lot of people ask me also, what is the best age to freeze eggs? So the best age to freeze eggs is less than 35. So this graph basically shows you the proportion of patients that freeze their eggs who achieve a 70% live birth rate. And your proportion is much, or your chances of having a live birth rate are much higher if you freeze your eggs early. So, if you're thinking about freezing your eggs, think about it sooner rather than later. And ideally, it's freezing your eggs before 35 years old. So again, most of the time you can get by with one cycle of egg freezing when you're 34 years old. But if you have a higher maternal age at the time that you're freezing your eggs, you probably need 2 IVF cycles to achieve the same thing. Now, the other thing that we discuss a lot in the clinic is, well, what happens if I do receive a diagnosis of infertility? So I'm not ready to freeze my eggs, but I am ready to start trying. And what if I become infertile? How much is IVF going to cost me? Now, the good news in Quebec is that we have one RAMQ covered cycle, meaning that the RAMQ is going to cover the cost of egg retrieval, egg freezing, and every single embryo transfer from that cycle. So if you have one embryo, they cover the cost of one embryo transfer. If you have 12 embryos, they're going to cover the cost of each one of those embryo transfers. Now, say, for example, you do an IVF cycle and that doesn't work, or you're not eligible for the RAMQ covered cycle. So if, for example, your partner has had a vasectomy or you yourself has had a tubal ligation, you are not eligible for an IVF cycle. So if either you fail your first IVF cycle or you're not eligible for your covered IVF cycle, the cost of an IVF cycle in Quebec is around $9,000 just for the ultrasound monitoring, for the teaching of the medications, for the hormone level monitoring, for the egg retrieval. And then for the fertilization, most clinics will recommend that you do something called intracytoplasmic sperm injection, which is taking the sperm and putting it directly into the egg. That has an extra cost of around $2,000. And the embryo transfer itself, if you're doing it on the same cycle as the retrieval, will cost you $1,200. So ballpark, you can expect to pay $10,000 just for the egg retrieval. And then if you're freezing embryos, every single time that you do an embryo transfer, it's going to cost you $3,000. So IVF is very expensive. Now, what are my pregnancy chances per embryo transfer? Well, that depends on maternal age. So in Quebec and in Canada, on average, every single time you transfer an embryo and you're less than 35, you have around a 40% chance of getting pregnant. So all that says is that you have a 40% chance of having a positive fetal heartbeat at 6 weeks of pregnancy, but it does not give you your chances of live birth per embryo transfer, which we're going to get to in the next slide. And as you can see, the chance of getting pregnant per embryo transfer really depends on maternal age. So the chance of getting pregnant per embryo transfer decreases with increasing maternal age, but your chances of miscarrying every single time you get pregnant also increase with maternal age, such that the ballpark chances of live birth per embryo transfer for all maternal ages and for all embryo quality in Quebec is around 30%. So that's what you can expect from an IVF cycle. Now, say, for example, you've delayed your fertility plans, or you haven't banked any eggs and you don't have enough eggs to be able to do an IVF cycle, and your fertility doctor recommends oocyte donation. So it is possible to go get younger oocytes from a donor, bring those eggs to Quebec, have them fertilized with your partner's sperm or with donor sperm, and then basically implant an embryo from egg donor. That costs money. So usually we have these egg banks that have these collection of donors that will be giving their oocytes, and the pricing will vary by donor. So the donors that have the most chance of helping you succeed to get your live birth are donors that are between 20 and 29 years old, that have already had a previous live birth, or that have already helped another couple have a live birth, and having a body mass index less than 25, non-smokers, non-drug users, non-alcoholics. So if you have the ideal donor, again, it's going to be more expensive than an older donor or a donor that's not experienced. Now, if you're ordering a single lot of donor eggs, typically the single lot is going to give you 6 mature eggs, and most egg banks will guarantee that you at least have 1 blastocyst, which is 1 mature embryo for transfer. They will not guarantee the quality of that embryo, though. If you order 2 lots, that's going to cost you about $30,000 US. And again, most of the time you're guaranteed 2 blastocysts, so 2 transferable embryos. And if you're looking for any type of insurance policy, you can go to an assured risk type plan, where basically they'll send you X amount of mature egg lots, and they guarantee a live birth. And if you don't have that live birth, they give you your money back. So that can cost between $30,000 and $60,000 US, and you are not including the costs at your local IVF center. So this is just the cost to purchase eggs, and then you still have to pay for the IVF cycle at your local IVF center. So you can probably tag on an extra $10,000 to $15,000 above the price of donor eggs. So I'm mostly explaining today what the options of fertility are for a woman. There is fertility preservation for men. So you do have the ability to freeze sperm for an eventual use later on if you're thinking about delaying conception plans. But this is not something that they typically recommend in fertility clinics, but I think eventually it will become mainstream. But just the choice of banking sperm to eventually help with fertility plans later on, again, is something that we might see in the future, but it's not something that's recommended right now. Now, I'm pretty much done with the presentation today, but there's one thing I really did want to emphasize is that there are hidden consequences of infertility, especially physician infertility. So as physicians, we already have higher rates of depression, suicide, and anxiety, and higher rates of psychological distress. Now, if you add on infertility and you add on fertility treatments, you are increasing the levels of psychological distress. So in a patient population that is not a physician patient population, you have 60% higher anxiety rates in females undergoing fertility procedures and 40% higher depression levels than females that are not undergoing fertility procedures. And males are similarly affected. So again, if you are a physician that is going through infertility, it is hard. And there's a lot of psychological consequences that are associated with that. So in conclusion, all I wanted to say today is that family planning is just as important as career planning. Delaying childbearing has consequences, but there are options for fertility preservation, and maintaining a healthy lifestyle might actually prolong your reproductive lifespan. So with that, I think we have a few minutes for any questions, and I think I'm done.
Very big thank you, Dr. Geneviève, for this excellent presentation, very informative and very important. I do hope that you get a chance to present this to all the residents who are starting. I think it would be an important presentation to give to all the new residents. I can tell you I have a question for you, because it is a topic that I do like to bring up with female residents, and it sounds like I need to bring it up with male residents probably a little bit more often. And it's usually, when I do bring it up, it's usually met with, it's not going to happen to me. I have good genes. My mother had me at 37. I'm super healthy. And I feel that, a lot of women don't seem to take it that seriously, or don't think about it very much. So my question to you is, obviously, you talked about age, you talked about obesity. Is there, a healthy lifestyle, all of that? Is there anything else someone can do? Like, for instance, looking at egg reserve in the ovary, or are there any kind of risk scores that could predict that people can look at when they're sort of 29, 30 starting residency, aside from the obvious ones?
So yes and no. I mean, you can do an AMH, which is an anti-Müllerian hormone level, but at the same time, the AMH doesn't necessarily correlate with reproductive outcomes. I think the single most important message that I wanted to give out today is just for any resident, any med student, any young career physician that does want to have a family, just start the conversation early. I'm not necessarily saying have your kids when you're a resident or a med student, but I am saying make sure that you take other financial um, steps, or that you do take fertility preservation steps to be able to either pay for fertility options later on, or be able to preserve your material for later use. I really don't think that we should be doing an AMH on everybody, but I really do think that it's at least something to think about, because infertility does happen. And when it does happen, it is hard, very hard. And you can never underestimate the psychological repercussions that it has on the patient and her family, as well as her partner.
Fantastic. There's lots of questions in the chart, in the chat, so I'm just going to go through them. Have stem cells been used to create oocytes?
Yeah, and if you want to do that, you can go to the US and pay $20,000 for something that is completely unproven. They haven't had very much luck in improving live birth with injecting stem cells into ovaries. So maybe it's something that's going to happen in the future, but I would not say in our reproductive lifespan. So please do not take the promise of these new technologies as something that's going to save your fertility later on.
Is there something as too soon for freezing eggs, like in late 20s?
No, no. So the ideal age to freeze eggs would really be between 20 and 30 years old, or at least before 34 years old. There is a higher chance of having embryo aneuploidy or abnormal eggs when you're less than 18. So I'd say, as long as you're between 20 and 34 years old, that is a very appropriate time to freeze eggs.
Thank you. Ningzi is going to make sure that this is saved for residents in the internal medicine program. Thank you, Ningzi. I agree with that. There's a question here about IUDs preserving fertility or hinder future chances.
Unknown, probably doesn't have much of an effect. But at the same time, you have to counterbalance any type of contraception against the potential of childbearing earlier on. So, would the off chance, very, very small off chance, that oral contraceptives or IUDs affect your fertility change your decision to delay childbearing, or at least not take that chance of getting pregnant? I don't think so. So, the science is saying no. Maybe in 30 years we're going to see differently, but for now it's no. And if you need a contraceptive, take any contraceptive that suits your lifestyle. So if an IUD is better for you just because you always forget to take your pills, then that's the way to go.
Can you comment about autoimmune features in pregnancy and miscarriage?
Yeah. So most of the time, if you have an autoimmune disease that is stable, you haven't had any exacerbations, and you're doing well on your medication, you're not supposed to have decreased fertility rates or a higher pregnancy loss rates. And you're supposed to be able to reproduce just about the same as the general population. However, patients with autoimmune disease are always in a special category. So whenever they do have recurrent pregnancy loss, or they fail several IVF procedures, most of the time we will try and modulate their immune system to try and have them, either implant better or stay pregnant. But that's an individualized case basis. But by and large, patients that have a stable, well-controlled autoimmune disease do not have higher rates of infertility or pregnancy loss.
Before I go on, are there questions in the room before I go on to the chat? Mark has a question here. Mark Roger. Go ahead, Mark.
Can I ask a question?
Thanks very much. It was an excellent presentation, thought-provoking call to action. I wonder, just from a policy perspective, from medical schools, both at UGME and PGME levels, and even departments at sort of a faculty level, any thoughts about sort of policy initiatives that could make sort of family planning
easier? We're going to get into a bit of a debate, but I was actually talking to Chris Tsoukas about that. And, there's a lot of requirements for residents to go away to be able to have, a university-based position. And that really does interfere with family planning. What they do in the NASA is really interesting. So female astronauts have to get a lot of education under their belt, and usually their first space flight is around 38. So basically what they do in the NASA is as soon as a woman enters the program, they actually do their IVF cycle. So they do their fertility preservation. They have their first space flight at 38 years old, and then they have an entire year to try and get pregnant with those embryos before they prepare for their second space flight. So I think, the best policy would be being able to make sure that your residents and med students understand the implications of delaying fertility, make sure that they have all the information that they need, and ideally having them access fertility preservation if it is something that they are thinking about long term.
I see Dr. Tan, that looks like you want to say something.
Yes, if you don't mind me interrupting, okay? So basically, I think there was an excellent lecture, okay, that you gave. It'd be great
Thank you.
to send all of us your slides, okay? Because it's very, very informative, okay? I would like to say, first and foremost, okay, that I believe that every woman in the world should freeze their eggs if they have a chance. And I'll give you 3 or 4 personal stories, okay? First, yesterday I saw a patient. She's 44 years old, okay? She had 2 daughters. And lo and behold, the daughters were killed in a car traffic accident. And now she's 44 years old, no more chance. Okay? So I told her I'll try for her an IVF cycle. If it doesn't work, she did egg donation, which is obviously a big thing for her. I remember 15 years ago when I was the chief at MUHC, a doctor at the MUHC came to see me. 39 years old, she will remain unnamed, and she was in tears because her husband was happily married to her and also a physician at MUHC, wanted to divorce her, even though they had been married for 12 years and they had 3 children. And she told me, she said, look, he's going to start another new life now with this other younger woman. But for me, I've got no one in my life. I expect to meet someone in the next few years, but by that time it'll be too late for me. Okay, so I did freeze for her for 20 eggs. Okay, but she was 39, not so good anymore. Okay, so many stories. Even myself. Okay, when I got married, my wife and I agreed to have 4 kids. We had 2 sons. The sons were nice, okay, but they were very difficult for them to look after. So my wife was at Oxford at the time. She said, look, if you want me to have a 3rd child, it's fine, but you must do sex selection for the girl. Okay. However, I was just coming to McGill at that time. I said, look, I can't really do that because, I'm just coming to McGill as a new chief and chairman. And for me to start an IV center there, and the first thing I do is to break the law by bringing to the USA to do it. Sounds a bit funny. That's why I didn't do it, okay? Many years later, she changed her mind and she was prepared to have a boy or a girl. But by that time, she was too late. She was in her 40s, okay? So again, that's why many stories. So I think everyone should freeze their eggs, okay? The first thing, okay? I don't think I think anyone, I do freeze even at 38, 39, 40 years old, okay? But I tell them that obviously if you're older, you freeze your eggs are not as good anymore. So I suggest to them that how many eggs they freeze depends on how many kids they want to have. 1, 2, or 3, whatever. But
thank you. We're running low on time. Dr. Genest, any comments on that? A different approach that Dr. Tan is. Dr. Tan used to be our chief of fertility. I don't remember the details, so he's coming from a place of a lot of experience. Any comments?
I can say personally what I would recommend to both my daughters, and I'm paying for their IVF cycle if, by 34, they still aren't decided on children. So that's my position. But I think, again, every couple needs to decide for themselves what's right for them. I would advocate, ideally have some eggs in the bank because we have the technology for it. And it just gives us options as women to not settle for the first partner we see, or to be able to delay childbearing and have a little bit more freedom in terms of how we want to plan our family. But that's me.
Thank you. Yes, there's comment here about the ethical dilemmas. Dr. Genest, there are many questions left or comments left in the chat, all very, very positive. People are extremely happy with this lecture. it was really a fantastic lecture. So thank you for sharing this with us. I invite you to please stay on the chat. So Sylvia, let's keep the link open, and perhaps you can answer some of the comments or questions that are outstanding. It is 1 o'clock, so I will have to close out the presentation. But obviously, there's a lot of interest in this topic. So a very big thank you to you. And those of you who want to have the answers to the questions in the chat, please stay on, and I'll ask Dr. Genest to answer them in writing there, Geneviève, if you can. Thank you so much. I wish everybody
I'll try. Thanks for having me.
Thanks, everyone. Bye-bye.